Welcome back, everybody. My name is John Wong. I'm Chief of the Division of Clinical Decision Making at Tufts Medical Center, Tufts University School of Medicine here in Boston, Massachusetts. And I'd like to acknowledge and thank in particular the Gordon and Betty Moore Foundation for sponsoring this research as well as this symposium. And a special shout out to Jillian, Lisa, and Kathy for helping arrange and organize this session, as well as all of the grant reviews. And a special shout out for the behind the scenes, Angela, who's been keeping us on time. It's my privilege and pleasure to start this second panel, and I'm delighted to have over 150 listeners and participants watching. For our fourth presentation of this day, I'd like to introduce Jag Tatwell, who is the Associate Director of the Institute of Technology Assessment at Mass General Hospital and an Assistant Professor at Harvard Medical School. And the title of his presentation is Estimation of State-Level COVID-19 Immunity in the United States with Implications for Reopening of Colleges. Dr. Chatwell.
Thank you, Dr. Wong, for this introduction. It's my honor to be part of this initiative, great initiative. And I'm very much excited to share our work that we have done in the last 6 months or so. Next slide, please. Before starting, I would like to thank the great effort of our team, which is a multi-institutional consortium we developed over the last 1 year. These are the team members. Next slide. So we had two objectives in this work. First was to estimate the seroprevalence of SARS-CoV-2 due to past infections, and then adding immunity because of vaccination after the availability of vaccines recently in each state using our COVID simulator. Second, we extended this analysis to inform safe opening of more than 800 colleges and universities in the US. Next slide, please. So this is we used COVID simulator, 19 simulator. It's a publicly available online tool. The methodology and all the details are available online. We have, for each state, we are simulating the epidemic and multiple outcomes, including daily deaths, daily COVID cases, both reported and unreported, active COVID cases, which is an estimation from the model, a few other things like ICU admissions and hospitalizations. Next slide. The model has been influential in informing some of the policies and has been cited heavily by the media. Here you see some of the screenshots. One of the key highlights was in Rachel Maddow's show early in April. And then in the left two screenshots, you see that the governors of Massachusetts and Georgia answering questions directly related to the use of COVID-19 simulator to inform their policies. Next slide. Coming to the first objective, I'll directly jump to the results because of the short time duration of this presentation. Next, so we first compared the model estimated seroprevalence of SARS-CoV-2 with the published study, a cross-sectional survey that was done last year between August and September. Here you see 4 panels, each panel representing different time points. And if you pick within each panel, the gray lines represent the reported uncertainty that was estimated by the study. The red dots represent the model estimations of the seroprevalence for each state. For 35 states, the model estimated seroprevalence was within the range of the reported values, but for 15 states, the model estimated much higher seroprevalence than the ones reported in that study. And interestingly, in most of those states where we estimated higher seroprevalence, those states had higher peaks. They had early peaks in the pandemic in April and May. So we believe that the seroprevalence study that was conducted in August and September may have underestimated the true underlying seroprevalence in those states. Next slide, please. So this is the movie that's showing how seroprevalence changed in different states over time, starting from March till the end of last year, December. And we saw considerable heterogeneity between the states and regions. Northeast, where the seroprevalence was much higher early on, it over time spread to towards the south and towards the west, and then rest of the country. Next slide. So this screenshot shows the range of seroprevalence between 4 to 40% at the end of December last year, just before the vaccines became available. And 13 states had a seroprevalence of about 20%, which means 1 in 5 individuals in those states was infected with SARS-CoV at some point in the last 1 year. Next slide. Then we added the availability of vaccines from January onwards. That means that we combined the seroprevalence from past infections and immunity because of infections. We see that the total population level immunity varies between 32 to 67%. Of note, none of the states have reached the so-called herd immunity safe threshold, which is somewhere between 75 to 90% for safe opening of the lifting of restrictions. Next slide. We have developed this COVID immunity tracker, an online tool, which is updated every week as we get more data. The tool provides rapid, low-cost means of estimating the progress towards population level immunity over time. Next, please. So moving to the next objective, which was extending our work to inform the opening of colleges and universities. Next slide. So we first looked at how students travel from one state to another, which is well known, but we captured this using the Sankey diagram, which shows on the left side the movement of students from the states, and to the right side is the 10 largest states. As expected, there's considerable movement happening. So we combined this movement of students with COVID simulator and looked at what would be the active cases in those states if colleges open in different time points in the month. And then using this information, next slide, we evaluated estimated the class size to keep COVID-19 cases count below 10 on the first day of opening. And you see these in the columns from April to August. April we can ignore, but we look at May, June, July, August, we see that in most colleges, we can start opening 100% if the threshold is below 10 for opening the colleges. And these are the 50 colleges, largest college from each state. We have the same results for 823 colleges total. We can look at more stringent definition if we want to keep the number of cases below 1 on the first day of opening. That's in the next slide. And here we see that by June, some colleges can have full 100% in-person classes, whereas in most colleges by fall, they should be safe to open. Next slide. So key findings that colleges can safely open somewhere in fall, and in some colleges can open in summer as well. We still believe that some precautions would be needed because the transmission is much higher in colleges than in the community. And last slide. And that I would like to thank you all for your attention and the funding we have received from the Moore Foundation, the Johns Hopkins support, and the SMBM initiative. Thank you.
Thanks, Jag. I want to remind the audience to put your questions into the Q&A, and we'll open up those questions at the conclusion of the first panel presentations, all 3 panel presentations. It's my privilege and pleasure now to introduce Erica Gralla, who is an associate professor in engineering management and systems engineering at the George Washington University. She will be presenting to us her work and her team's work on discrete event simulation for COVID-19 testing, identifying bottlenecks and supporting scale up. Dr. Gralla?
Thank you. I'm very pleased to be here and to share our work with you. I just wanted to acknowledge my team at the beginning here. We have a very multidisciplinary team with folks from epidemiology, from industrial engineering and systems engineering, and from microbiology and immunology. Next slide, please. So the key question that we wanted to address was about testing. And I have here some headlines that are probably familiar to many of you from earlier in the pandemic. There were massive bottlenecks with testing, and the turnaround times were so long that it was almost pointless to get tested in some cases. And so we started asking, how can we understand the source of these bottlenecks? What's the problem here? And then how can we think about ways to overcome these bottlenecks and scale up testing capacity to the level needed to safely reopen society? And some of the challenges that you've probably heard about were supply chain issues, fluctuating demand, dealing with regulatory requirements for lab testing, and then the needs of different kinds of stakeholders like clinicians and public health. Next slide, please. So our approach to this was to look at the testing process first at one specific laboratory at the University of Maryland, which set up a partnership with the state of Maryland and does now large-scale testing for the state. And the process is shown here in the diagram. Basically, the testing is performed at all different sites, public sites, nursing homes, universities, and others. And then all of those samples are brought to this laboratory. And then the testing process is performed, and then the results are delivered back to the different clients. There's a lot of different information systems that have to be matched up here and different sources of samples. Our focus is the process on in the laboratory itself, and then its interfaces with the others. And so there, very briefly, that's shown at the bottom. The samples are brought to the lab, they're matched with the orders, the tubes are uncapped and the swabs are taken out. And then they use a series of liquid handling robots to transfer the samples to deep well plates, to extract the RNA, to set up the PCR, to perform the PCR, and then the results are exported and delivered to the patient, to the clients. So we represented that process in a discrete event simulation model. And we use that model to, first of all, identify the bottlenecks, and then second of all, experiment with different kinds of process and resource changes to alleviate those bottlenecks. And then finally, we conducted a workshop and a number of meetings to translate those results to practice. Next slide, please. So the first goal here was to identify the bottlenecks. And what you're seeing here on the upper left, the graph was intended to look at what is the overall capacity of the lab. And so you can see that as the demand goes up, that's the x-axis, the number of tests conducted per week, that's the y-axis, doesn't get above 33,000. So that's basically the capacity of the lab in its original manifestation. We can also look at turnaround times, which is on the upper right, but I won't focus on that right now. And then the question becomes, okay, if our capacity is 33,000 samples, what's constraining it to be that capacity? So the bottom graph is how we determine that. It shows at different levels of weekly demand for testing, what is the utilization of each of those process steps. So anything that's 100% utilized is a bottleneck. It's constraining samples from moving faster through the process. And there's a clear bottleneck in this laboratory, and that's the blue bar, the deswab step. Okay, and so the deswab step is 100% utilized, which means that it's constraining the capacity. Next slide, please. So now that we've identified that bottleneck, we can think about ways to eliminate it. And the photos show kind of what deswabbing actually looks like. You have to pull this little tiny swab out of a little tiny tube while you're dressed in a bunny suit and working in a hood. It's very tedious manual work. And what our models showed is that if you could eliminate the need to do that, you could double the capacity of the laboratory, that step alone. And so the laboratory found a way to enable the collection sites to discard those swabs so they don't even arrive with swabs inside them. And then you can see that, if you can do that for most of the samples coming in from most of the sites, then you can get capacity significantly up with very little investment. Next slide, please. We also looked at other changes like repurposing instruments, multiplexing the assay, extending the shift lengths somewhat. And we found that in this laboratory, those additional changes didn't provide very much gain in capacity. And so if you want to do yet another significant expansion of capacity, you have to invest in multiple process steps at the same time, either in more person time or in more equipment. And so next slide, please. So finally, what we showed here is that capacity gains are possible with very limited investment, and that the models can help to prioritize what those investments should look like. And generally, we found that process modeling is very valuable for expanding testing, but we've seen very little of it in this pandemic. So we're working on generalizing our model to other lab processes so that others can take advantage of this approach. Thanks.
Fantastic. Thank you, Dr. Rala. Again, I'd encourage all the listeners to put their questions into the Q&A, and It's my pleasure to introduce, apologies to my Dutch colleagues, Stantje Dijk, who is a PhD candidate in health, economics, policy, and law at Erasmus, who will be presenting our work. As you can see, I'm also a co-author on this, on emerging therapies for COVID-19, the value of more clinical trials.
Thank you very much. So welcome to this session on indeed the value of more clinical trials on emerging therapies for COVID-19. You'll see the rest of the team working on this project on this slide. We'd like to thank the Gordon and Betty Moore Foundation, and we have no conflicts of interest to reply. Next slide. So in this pandemic, we've seen a rapid increase in the number of studies investigating treatments for hospitalized COVID-19 patients. But at some point, we need to discuss whether or not there is value in performing more randomized controlled trials for these therapies after promising results have been reported. And then there is a trade-off between giving early access to patients versus gathering more information. At the bottom of this slide, you will see the different treatments that we have included in this study. Next slide. There are two questions that we need to ask. On the one hand, do we approve or delay the approval of a treatment? And then secondly, do we conduct more research or do we stop doing research? Next slide. And that results into 4 different options. Either we delay the approval and only apply the drug in research settings, or we give general approval, which means that the entire population can benefit via emergency use authorization. And then we approve the drug with further research. We can also approve the treatment, but stop doing research, or we can reject the drug altogether. Next slide. To get to the point where we can make a decision which of these strategies to choose, we need to go through several assessments. Whether or not the drug is cost effective, what is the probability that it is cost effective? What is the benefit of approving the drug and giving emergency use authorization, or the benefit of doing more research? What are the costs of doing more research, and do those costs do the benefits outweigh those costs? Next slide, please. To answer this question, we used a cohort state transition model with hospitalized COVID-19 patients who either recovered from the hospital ward or the intensive care unit. And we followed them across their lifetime using a US healthcare perspective. Next slide. We go through several steps within our analysis. We first conduct a cost effectiveness analysis, followed by a probabilistic sensitivity analysis, and then value of information analysis on only the parameters relating to treatment effectiveness, for which you calculate the expected value of partial perfect information. We calculate the net benefit, expected net benefit of research, and the net value of more research versus approval, which we will come back to in 2 slides. Next, please. First, the results from the cost effectiveness analysis. We see that baricitinib, remdesivir, dexamethasone, and remdesivir were all cost effective at a willingness to pay level of $100,000, and the other treatments were not. Although we should note that hydroxychloroquine is really at the border of being cost effective, but it would be decrementally cost effective. So we would be saving costs because less people will survive. Next slide. Then we need to calculate the net value of each of these treatments and find out which of these quadrants has the highest net value for each of these treatments. So in order to do that, we need to take into account both the future patients who can benefit from the new information that we get from another RCT, as well as the new patients who will benefit from the treatment after it's implemented, but also the current patients who are not or are receiving the treatment based on the decision that we have made. And then we calculate each of these quadrants for each of the treatments in order to find the optimal net value. Next slide. And here you will find our main results. In the case of hydroxychloroquine, we found that the highest net value was only in research quadrant. So applying the drug only in research settings, but not widely implementing. None of the drugs had the optimal value in approval with research, so the emergency use authorization, and approval was the optimal strategy for remdesivir, dexamethasone, and baricitinib remdesivir, all compared to care as usual in their own respective trials. So we're not comparing these drugs to each other, I should note. The other three drugs were all rejected, and so their net value becomes zero because the default strategy remains care as usual. Last slide, please. And so in conclusion, value of information can really help us to determine whether or not we should implement a drug, whether further research is justified. And in the case of the pandemic, where resources are scarce, they can really help to make this decision more objective. Thank you for your attention, and our entire team, except for one member, will be happy to answer your questions in the panel.
I can answer questions. No, just kidding. I'd like to thank all of the presenters, and I'd like to invite them to open up their screen to address and answer any questions. Let me open up the questions, starting perhaps with Jag while we're waiting for people to type in their questions. Jag, I noticed the discrepancy you found for states early on in the epidemic with your estimates of the antibody prevalence or immunity prevalence developed by natural infection, due in part to the lack of testing in those states. Can you say a little bit about what you think the implications of that are on state policies for those states which had underestimates?
So, so the implications for the states could be that when they're looking at lifting of restrictions, which is a combination of how many people have been vaccinated plus past infections, they may be underestimating the overall population level immunity. So they may be playing more safe than needed, which is not a bad thing to some extent. That's one implication I can think of.
So thanks, Jag. I'm going to move on to Erica quickly. You know, you mentioned how few labs actually sort of break down the processes and the bottlenecks within labs to process the samples. And it brought to mind whether or not your lab ever reached capacity where you had to back up. And then secondarily, how are you thinking about generalizing this and making it available to other labs to assist them with throughput?
Yes, good question. So the first one is the easier one. They did reach capacity around the holidays, sort of in the lead up to the holidays this past year, when we were seeing big surges and people also wanted to feel confident traveling. And this particular lab kind of people just worked longer hours and longer hours, but that's not sustainable for more than a week or so at a time. But we did actually see that. And it could have gone on longer had vaccines not come out started to come out shortly thereafter. And then of course, this is a research lab that doesn't want to be doing this forever. So eventually the capacity in the country is going to go down further because people are going to go back to their original purposes. So we think it's still a kind of a relevant question. And then for generalizing, we were surprised too. It's not to say that individual commercial labs aren't optimizing their processes. We have no insight into that. We just haven't seen much published gray literature or otherwise on the process of this. And working with the people who run these labs are not process engineers by and large. And so what we're looking at is now a couple of other labs, one at GW and at other places, to try to understand what needs to change about the model and to look for what are the things that are pretty constant and what are the key parameters we need to know. And then we're hoping to be able to make a public facing interface where labs can type in the few key parameters about their labs and be able to predict their own capacities and look at what would be the most high impact investments for them to make, where their bottlenecks are and what they would invest in.
Thanks, Erica. And Stanjay, I don't want you to be left out. When I think about our work, I think about different policy and research silos. So for example, here in the United States, the FDA is in charge of emergency use authorization, and they're very distinct from the NIH, and they have separate budgets. And I'm going to open it up. You can throw out a helpline to anybody you want to help you with the answer to this question, as I see our team is all present.
So could you repeat the exact question again? So the difference between the FDA's approach?
Yeah, so, we're talking about, should you approve a drug? Should you do additional research? The funding for those two things go to different policy bodies within the United States. One is the FDA, the other is, say, NIH to do the research, the FDA to think about approval. The budgets for those don't overlap. I mean, they come out of, say, Centers for Medicaid, Medicare, and services, as well as other private funding. So can you help me think about how policymakers should be thinking about this work, looking at value of information and sampling, et cetera?
Right. So to the other members, please feel free to contribute as well. I think one of the major challenges is if all of these funding come from different resources, then who is the person or who's the organization who's really taking a look at cost overall and benefits overall for the entire country or the entire world? Whereas, for example, I can also imagine that a lot of policymakers tend to think more short term, whereas we're modeling over a lifetime. But if you have a limited budget for a specific couple of months in advance, then you might take a different choice than which might be the optimal one in the long term and for the entire population. Feel free to add anyone else on the team.
Yes, I agree with Steintje's answer, and it really depends on your perspective. And I think we're trying to take a bigger picture overview type of perspective. So in fact, assuming that, in the long run, that the bottom line is that as a country, we have to pay for healthcare and we have to pay for research.
And perhaps I can also add that there is this need to coordinate the decision-making between funders of healthcare and funders of research. And funders of research include both public and private organizations or companies. So we should definitely try to coordinate this decision-making, which may be more challenging depending on country. It will also differ, as John mentioned. It will be something different in the UK and something different in the US, where we have different healthcare systems.
Thanks.
But that was a very good question.
And I hadn't prefaced it before telling you all. We have a bunch of questions in the chat, so I'm going to ask you to try to give quick, short answers. The first is for Erica. It was fascinating to see the granular analysis of the testing process, identifying the de-swabbing bottleneck. I can imagine the frustration at the lack of response from laboratories and policymakers to try to avail of this seemingly low-hanging fruit for reducing transmission. It seems to mirror a similar reluctance to roll out more widespread rapid testing too. What's your take on why decision makers seem to have ignored these policy options? And why don't we see more integration with engineering and healthcare? I'll say we are seeing it, but why not more?
Yes, I would say what John mentioned is a good part of the answer, is just that it's sort of hard to make those, to connect those dots, right? And it takes some time to put the models together. So it took us a couple of months to get this answer on the table for this one lab. Should be faster the next time, right? Because now we can easily adapt the model to other places. That's part of it. The other part of it that I want to mention is that the policymakers may not know who to ask or know that this option is available. And sometimes there's just so much hurry to get, there's contracts out there for this, and there's so much hurry to get the contracts on the table that there isn't the chance to think about how to, sort of optimize those processes within them.
Thanks, Erica. I skipped over one that was earlier. Does a pandemic situation justify the same willingness to pay thresholds? Or would you suggest a different level than for, quote, conventional non-pandemic treatment approaches? And I'm not going to answer that. Sanjay, I think that's for you or Miriam. Or
I can start with that. That's a very good question. Additionally, we've also had the discussion, not just for the pandemic, should the willingness to pay level be higher? Should it also be higher for the treatments that are decrementally cost effective? It could very well be. We have considered it as well. This is also one of the reasons why we're trying to also build shiny applications where policymakers who want to use the results of our investigation can also tweak these things, parameters such as willingness to pay levels, such as costs to their own country situation, to find out what are the results if we indeed increase this. But there are a lot of arguments that we can give that say, yes, we're putting all our resources into this pandemic to set it higher than it already is.
Thanks. I'm going to move on to a few other questions that we're going to try to answer within the next 3 minutes. I deeply appreciate all of the amazing projects and efforts. I think COVID-19 gave us an opportunity to show the importance of modeling to guide policy decisions. Considering the research modeling capital that we have built so far, how can we use this momentum to continue to expand the use of modeling to inform key decisions? What are the next steps, future directions, non-COVID related for the modeling groups? And I'll offer that up for each of you to give 1 or 2 sentences. So Jag.
Yeah, that's a great question. I don't know the answer. I'm hoping that I can end all my COVID work and go back to what I was doing pre-COVID, all the modeling work that's lagging behind. I don't know how we're going to use the machinery that we have developed. We have learned a lot during this process, and I'm just hoping that we'll stop working on COVID soon.
Erica?
I think I've been thinking about that a lot recently. I don't have a good answer, but I think publicizing it as we're doing and getting the work out there, and especially working closely with policymakers that we have access to, or with the decision makers that we have access to, the word will get around that this has been useful.
Antje?
I think for us, the methodology that we use can be applied to any possible field of disease. So definitely this model can be reused also for alternative diseases, or hopefully not future pandemics.
Dahlia has I think comment, VOI, sorry. My bias for value in health is clear here, I guess. I'm not sure there's a question there, but I'm going to go on to the next one. Was how was turnaround time impacted by de-swabbing improvements? That's for you, Erica.
I was just trying to type that one quickly. So the turnaround times are consistently less than 24 hours when the laboratory is not above its capacity, and when the demand spikes don't bring it way above its capacity. And so because the de-swabbing improvements improve the capacity so much, they will basically get 24-hour turnaround times consistently, unless we see another enormous surge.
So there's another question that Santa maybe you could answer in the chat, and I'm going to ask David Kim to answer his own question if he wants to. Because I think he has an answer. So David, unmute yourself, or can we unmute him? Perhaps not. So then, Stantia, could you explain again why tocilizumab is rejected? It is less costly but more effective on the CE plane.
Yes, I was just answering it in the chat. So it was in the left upper corner, but on the CE plane, that means that it's less effective, but saving a lot of money. But for us, the main driver for most of these treatments for cost was because more people are alive, so they incur healthcare costs. So we were, tocilizumab was also a lot more expensive. So it was actually less effective and more expensive because the drug treatment is so expensive.
And I think we're at 12:30 and there are a few more Q&As. And I guess I would ask you all to answer them online, and we'll now enter our second break. So thank you all for a wonderful session, and my colleagues, as well as Jag and Erica. Thank you.